So this patient presented after she had neurosurgery. So she had an interesting history of bilateral meningiomas that went around her carotid, and so she actually ended up needing extensive craniotomy to get to the tumor. So she recovered well after that surgery. So from a neurologic perspective, she was a great success. She'd gone through neurosurgery and she'd recovered really nicely. But when she came in, she said, something else was missing. And I think that was just addressing the facial deformity. So our treatment plan was using a combination of aesthetic and reconstructive techniques to try to improve her facial symmetry. So we used chemodenervation for her frontalis to get her brows in a more symmetric position, as well as using dermal fat fascia grafting to improve her temporal hollowing. So when working with patients to develop these reconstructive plans, one, a lot of times it takes multiple interventions, and it's a mix of like non-invasive and invasive procedures to get to the patient's goal. In addition, from a timing standpoint, a lot of times patients present not right away, but a year or even years down the line, and really it's never too late if they have facial deformity or asymmetry they want to address. So a lot of times, we sort of see where they're at, and then we talk about where we want to end up, and we work together to get there. And it does take time, one, to plan out the sequence of steps, but also the recovery and things like scarring and swelling, and it takes time, but down the road, we know where we want to end up, and patients find that over time that they develop a new normal and can go back to their normal routine. Already, she's reporting that she feels a lot better, and she's sort of, feels more like she did even before her initial surgery. So I think she's going to do well.